Right, after that. So I'm the jobbing end of the panel. I'm the clinician. I'm trying to develop services, and I'm trying to develop services that suit both clinicians and the people using them and try to solve the problem. The problem is not neurodiversity. The problem is the amount of people seeking help and the amount of help we've currently got. So I'm sure everybody has heard of ADHD, and I'm sure most people have heard of ASD. And I'm not getting into the politics of the naming of these things, but it is a huge subject. So it's everywhere in the media. I apologize in advance. These are all from one newspaper. I'm not promoting that newspaper. It's just the newspaper I happen to be looking at that seemed to have quite a lot of and I must say, the other thing I should say is to declare that there's quite a lot of neurodiversity in my family. And I was certainly one of the people who grew up with a dad who didn't know he had ADHD, but boy, did he. We used to, there was one time we were in an airport and my mum said, it's time to go for the plane. My brother said, but they haven't called our name yet. That is how we lived as children. Keep that in mind. Okay, so it is everywhere. There's a lot of interest in the public, and quite rightly, between 2 and 7% are reckoned to have the diagnosis, whatever the diagnosis would be. And about 50% of people would carry this into adulthood, and some would have it that it was increasing. Again, a controversial subject. So, more media. I'll come back to the medication issue in a minute, but certainly this is a very divisive subject from both sides. Clinicians use the word swamped. We are swamped, but that's only because our services aren't set up to do anything about it. And we feel kind of helpless. And the public feel we have a massive wall that you must climb over to get to some sort of diagnosis from us. Celebrities, there's lots of celebrities. Almost every comedian in Britain now seems to have ADHD, and they probably do. But certainly they bring the profile up within the public. And then, of course, there was the Panorama program. I don't know if anyone saw this, about private diagnoses versus NHS diagnoses. And again, great splitting, more division going on. Yet more media, and I'd like to bring your attention to one at the top there. So this is an NHS screening system. This was in the paper this weekend, actually, in Yorkshire, that they put in a digital screening system to try and help with the waiting times, try and organise the information we need to possibly screen people into our system. And it ended up that not a single appraisal, not a single person got through the screening. So we've got to get it right. So one issue is that the main treatment, certainly for ADHD, and I don't think this should be correct because I don't think it is the first line treatment, is medication. And an awful lot of people coming to our services are looking for some medication. However, as you may or may not be aware, there is no medication at the moment for ADHD due to a global shortage, which started in the States and has actually now ended up in England and Scotland. And a lot of the medications we use are just not available at the moment, which has caused a great deal of distress to people. And we don't know when they'll be coming back. It then leaves a big gap. What are we going to do? So, to summarize the situation, the number of people seeking a formal diagnosis of ASD or ADHD has increased at least 3 or 4-fold in the last 4 years. Our current service can't cope with this increase in demand, and some are having to now prioritise only the most severe cases. And where really does that lead everybody else? So this is, I guess this is an overlap of various different neurodiversity conditions, syndromes, descriptions. I don't mind what we call it, and the problems that people might face. And one thing you will see is there's an awful lot of overlap between these different conditions. So, no, if this works, this works. If it doesn't, it doesn't. Maybe it doesn't. But there's also a lot of positives. There's a lot of positives that can come from these different areas, and not everybody sees it as a disorder. And that is the point. For some people, there are positives. For some people, there are negatives. In realistic medicine, we have a kind of medical model. Now, when I'm using medicine here, I don't mean medicine as in something you take. I mean medicine as in what the health service offers you. It isn't always a disorder. Sometimes it's a benefit. But if people find it a problem, they seek a solution from us. And I think there's a difference. I'm quoting Prem Shah, he's one of my colleagues in Edinburgh, who talks about socially important ADHD and medically important ADHD and the difference between them. And one is not more than the other, but often people are just being asked to be diagnosed. And there's a real lack of alternatives. And realistically, we cannot deal with the demand in our services. So if you think about it a bit like hip arthritis, you've got a pain in your hip, nobody's going to deny that you might have arthritis, but do you get onto a waiting list for a hip replacement? No, because there's grades of severity to do with functioning and to do with technicalities actually of the bones. So the next two slides are not for reading. They are just to say, this is what medics in ICD-11 would diagnose ADHD. And actually, it's a bit vague. It says things like, you've got to have it across multiple settings, outside the limits of normal variation, and may or may not be there before the age of 12, probably before, but you might not have noticed it. So for clinicians, this leaves us in a bit of a sort of grey area. ASD is similar. This is a description. Again, you don't have to read it, but this is what a medic is being asked to do a diagnosis on. These are the technical terms. That does not negate all the people's experience of it. What it does mean, though, is we have to choose who gets a diagnosis and who doesn't. And our services are set up for if you have a diagnosis or you don't. But the point is everyone's different, and that's the whole point of diversity. So each person with ASD will not be the same. Some people might have more communication problems. Some people might have more limited interests. They'll all reach the diagnosis, but they won't all be the same, and they won't all need the same help. I'm going to run through this quite quickly. So just to give an example of the rise in referrals, this is my sector in Edinburgh. I think what's interesting is the lockdowns certainly made a huge difference to the amount of people being referred in. The referral rate didn't decrease at any point, apart from the first month of the first lockdown. They kept coming, they kept being referred, and it certainly went up towards the second one. And that's been sustained. This is now till November last year. And you can see the line at the bottom is the line that our particular sector can assess at any one time, and it's fairly exponential. So the blue lines are the neurodevelopmental referrals going up. And this is the Edinburgh waiting list, again, going up. So what can we do about this? Well, NATE, who are the National Autism Implementation Team, produce some guidance. They work for the government. They produce some guidance to try to, I guess, stratify rather than people just having it or not having it, but having it into a mild, moderate, severe, and also what kind of things might be helpful, because we don't have a staged care system for this. They produced some evidence, and they also produced some guidance on what support might be helpful for people. I'm coming back to this. In Edinburgh, we decided to try and develop the screening for severity, and I can speak to anyone who wants to about that in the break. But just to say, a lot of pragmatic things on the ground don't translate to strategy, and sometimes you have to invent things as you go, maybe with not enough time for research. Instead of medicine, what else works? Well, most of the studies are pretty small, they're fairly narrow. I'll use the phrase that's used in every talk today, no one size fits all. And service users certainly have been involved. They produce the majority of the advice on the internet at the moment. But I was struck by this study on a psychoeducation group for people on a waiting list that actually studied 5 people. So we don't have anything big and we don't have anything global. So Edinburgh produced some self-help packs. This is now back about 5 years ago. And if you probably can't remember that Nate diagram, but what you'll notice on this diagram, which is a quick process map of our current service, is we don't really have the blobs in any neat order, and the specialist third sector aren't even connected in any way to us. So on the ground, we thought we'd try and make a pathway with a website. That seemed to be our ambition. It was going to have information and helplines and information about local processes. However, this didn't seem very ambitious, and it didn't really match most of the NATE guidelines, which usually would knowing what your diagnosis might be will help you apply self-help better, that different people need interventions for different things, that people need access to support while they're waiting for diagnosis, not just after they've had it. And we need an evidence review for actually things that work in the area. So we thought maybe a digital solution might be a possibility. Now, this is a wish list. This is not a real thing yet. So we worked out what we might need from a sort of computerized point of view and what would our ideals be. We made a process map that would coordinate with this. And what we hoped to have was, so the clinicians, they wanted screening tools that you could fill out online, that you could collect the data without photocopying things, that you could, not computer says yes, computer says no, but that you could organize the data into a reasonable way. The people who wanted to use the system wanted something tailored to them. They wanted something that said, you've got problems with this, here's a possible thing you could use to help you. What people don't want is to fill out pages and pages and pages of forms that have no meaning to them, just because our service has said, here's all the forms, you have to fill them out to jump our wall. So in the system that we were hoping to develop, there would be tools that assess you. The later tools would steer you to certain interventions and support. The data could be captured at the end and passed on to the NHS system so that you weren't duplicating things. The support would be offered prior to any assessment. You might not need assessment after that, and local information in different modalities could be added as it became available. So where's the researchy bit here? Well, anxiety in neurodiversity is a big issue. Some would say there is no coexistence between anxiety and ADHD from a research point of view, but most people with the problem or with the experience of it, would say it's a significant problem for them. If you screen for anxiety and you have some sort of intervention, whether it's psychoeducation, whether it's a webinar, whether it's a group, whether it's a web group, whether it's CBT, and then you screen afterwards to see if the intervention has worked on a lot of people, and we're talking thousands of people going through our system, then you might actually work out what works and what doesn't, more than 5 people trying something. You could then take the effective modules and keep them. You could take the ineffective models and either change them or substitute them, and you're getting real life feedback on what is useful for the people going through the system. Okay, so the hurdles are many: the money, the content. We do not want, as services, to say what the content should be. There's plenty of that. We've been working with Claire from the Procrastination Station. She's got a very good website on what should be there. But it's more the structure. You need a structure like this to be able to work out if things are useful or not. The waiting time rules. This is a massive hurdle for clinicians. When does the clock start? When is it ticking? Are we providing a treatment or not? And future proofing, because more interventions will come, more ways of looking at information, natural language processing. A lot of the things aren't numerical in this. They're the qualitative part of exactly how it's affecting your functioning, what it means for you. AI, I've left it behind, but it's coming back. So you never know, future-proofing a system like this might be important. So I've put this up just because there's so much information that I'm not going to cover, and I'm certainly not going to cover all of the NATE, but I would strongly advise you go to their website if you're at all interested, because it has a huge amount of information on screening tools, on things they've advised, on Pathfinder. And that's really me. But if you want to come and find me afterwards, you can.
Thank you very much indeed to our 3 speakers for this session. We did start a little bit late, so I think we started around 10 past the hour. So that gives us just under 10 minutes for the panel discussion. I just want to thank all our speakers for giving very excellent talks and very different and interesting perspectives on the challenge of implementation, from policy, inclusivity, but also delivery on the ground. So thank you very, very much for those presentations. I'd like to now just invite some questions from our audience, please.
Yeah, no, thanks for talks. I mean, can I just ask about progress for us to have a system by which people can easily add their own information or outcomes into our electronic clinical systems? Because I guess, you know, things like Sharon's discussing in terms of innovating around some of these pathways relies on a structure to input that in, and it'd be good to hear what progress there is on that.
Yeah, I think I've been volunteered for that question. It's the best possible way to say that. So I think there has been progress. Is the thing I think I would say initially. We have a number of kind of key programs in Scotland just now. We have things like the digital platform and the digital front door, which will be then a kind of data conduit for a lot of information that flows between the individual and the services, for example. But I think we have to acknowledge that it is an incredibly complex piece of work that they're trying to achieve, largely because of how digital has evolved across Scotland, particularly in health and care services. So obviously the integration of health and care is obviously really key to that, because you want a kind of transition of data between the different types of services. I think the complexity of different data legacy systems is proving really, really complicated. I think what I would say is there's now a recognition, and a very strong recognition, that this has to be absolutely key to how we progress, not just as services, but also how we progress with technology such as AI. So I think it will become a much more significant priority as we move forward. So there has been progress, but I think it'll be quite a long journey, is what I would say.
I would just add as well that DHI are doing some really interesting work in this space with up in Murray, where they are kind of prototyping actually that you know, building on that person own data and actually being able to input that and look at the, you know, what that opens up for someone in terms of access to service and, you know, making that as easy and as smooth as possible. So there is some prototype work in development there as well.
Thank you for that question.
So good afternoon. So I would really like to appreciate and acknowledge the panel discussion and also the research presentation. So getting direct to the question, I really appreciate and like what Dr. Sharon Smith mentioned about the amount of help available and the amount of people seeking for that help. So as a Scottish government and also as an expert in this field, how can you promote help-seeking behaviors for those digital mental health apps?
Nobody wants this mic today. I mean, yeah, I think there's probably 2 or 3 things we have to do. I think we have to be very aware of how we shift people to a more preventative and self-managed approach to care, having more responsibility for their own health and particularly their own mental health moving forward. But I also think in terms of the use of digital, as I said in my presentation, it's really about building that knowledge base and the research and the evidence, which then reassures people that are delivering service, but also reassures people engaging with services moving forward. So I think, in addition to things like inclusion as well, I think it's really important that we have multiple strands working across the use of digital, not just within mental health, but across all healthcare.
I think I'd like to add that actually there's quite a lot of digital information in the area that I'm talking about. It's just, it sits completely outside us. It's charities, it's people with lived experience putting a lot of information down. But the thing is, it's not always matching what we would think might be a good treatment. And that, you know, I think matching them up together, but not controlling what's in there, but actually being able to have a chance to see if things work, I think is a very important thing. So I do think there's a lot of accessibility issues. Our systems always went around the edges and said you didn't have to do it, but actually a lot of people are already online, and it's just directing them to something that's connected with the whole circle.
Yeah, a friend of mine who does not have mental health issues told me he'd just got a smartphone and asked me if I'd come and help him set it up. And I said, have you tried going online? He said, that's what they always say. No, I'm not, I don't want to do that. So I said, okay, I'll come around and help. Have you got your SIM card? What's a SIM card? You know, all of the actual vocabulary and what's your password? Have you got enough letters in it, symbols and all the rest of it? So an ordinary member of the public, not someone with mental health conditions. So I think the task is quite enormous, actually.
Yeah, absolutely. And that's where, yes, you know, you might have the device and have the connectivity, but actually thinking about all those things like security and how do you actually develop a password that's safe, you know, all of those things we can just often take for granted if we're just using digital so much as part of our everyday lives and in our work. So, you know, supporting someone. And I think that's, you know, incredible, you know, you're able to provide that support. And I think some of the work that I've been linking in with, some in Scotland and some down in England, is around looking at that peer model of digital inclusion as well within mental health. So again, supporting, you know, someone that you trust and who's had, you know, a similar experience that you've had, actually supporting and enabling you to get online and showing you how to get connected. So
Something was at the end, he said, I'm totally stressed out now.
oh no. It's not easy.
Great question. I think We've got time for one more question. I think there's just a question.
Perhaps this is stating the obvious, but I wonder what your thoughts are on why the marked increase in seeking the diagnosis for ADHD should occur at the time of the epidemic.
Sorry, why? Couldn't quite hear that. Why?
Why did the attention seeking a diagnosis for ADHD happen to take place at the same time as the epidemic? Why did that rise take place? Do you have any thoughts on that?
I do. I'm not an expert, but I think one of the things was the lack of structure, people being at home, trying to multitask, trying to work, trying to homeschool. People rely on the structure of getting up, going to work. I think interpersonal difficulties of being stuck in places where you can't get out, causing more stress. And I think that probably caused it probably caused people to notice their neurodiversity symptoms more. And then because of that, they started seeking answers. And of course, everybody had problems focusing when they were stuck at home. So I think it just increased, and I think it's partly public awareness. I don't think that's a problem. I think it's a problem because we don't have services or interventions that we can do for that amount of people. Which is why I think something digital might be a more pragmatic solution.
Thank you very much. Thank you for that question. Thank you for all the questions, and especially to our speakers, Chris, Tara, and Sharon. I think one thing that you really made us think a lot about is the importance of the involvement of people at all stages of design and co-production of digital therapies. And I think that's a really important message for researchers in terms of starting that involvement at the very beginning of an intervention development and handing it through to implementation. Thank you, and I do not want to stand between you and your lunch. It's going to be a great time to do so. Please enjoy your lunch and you return that.